Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the role of nutrition in cancer prevention and survivorship with Dr. Melinda Irwin. Dr. Irwin is the Susan Dwight Bliss Professor of Epidemiology and Associate Dean of Research at the Yale School of Public Health. Here's Dr. Weiner.
You know, I like to get going just by asking people to tell me a little bit about what led them to pursue the career that they're presently doing. So maybe you could tell us a little bit about what brought you to public health, what brought you to cancer, and how is it that this has sort of magically all come together?
Sure, I'd be happy to. So I've always been active. I was an athlete for a number of years in my youth and competed at the Division I level in gymnastics in college. And I always thought I'd go into orthopedics. I had numerous injuries, knee, back, whatnot. But then in high school, my mom was diagnosed with breast cancer at the young age of 44. And this was in the mid 80s. And at that time, at least from my perspective as a 16-year-old then, there was one sort of breast cancer, one sort of treatment. You kept it quiet and you went on your way. And it really sort of rocked my boat a bit throughout college and thereafter in the way the lack of sort of information on cancer prevention and control, and specifically to me, the role of lifestyle factors, especially modifiable lifestyle factors in preventing or controlling cancer. And so I pivoted away from orthopedics and into an interest in cancer, but was really interested in more of the epidemiology aspect of physical activity and other lifestyle factors in preventing and controlling, partly because I met Barb Ainsworth when I was in graduate school at UNC Chapel Hill, and she was an epidemiologist. And at that time, I didn't know what epidemiology was. And she really explained to me the importance of looking at things on a population level. And you can see major societal shifts in how that might influence developing or dying from a chronic disease, in this case, cancer. And so I went on my way and pursued graduate training in that, as well as a postdoc looking at cancer prevention control with Ann McTiernan and really better understanding how to do trials, randomized controlled, rigorous designed trials. And then came to Yale in 2001 and was fortunate to really start my career looking in the post-diagnosis time period of how exercise, nutrition, and weight management affect numerous outcomes after a diagnosis of breast and other cancers.
Yeah, and of course, there is one huge societal trend, one that you do research focused on, and that is obesity. That if we look at it on an epidemiologic level, the increase in cancer incidence over the past 20, 30 years is at least partially related to the weight gain that's been seen among Americans.
Yeah, I think that's a really important way to look at it. When we first really start to document rates of obesity through the Centers for Disease Control, and obesity is defined as a body mass index of 30 or greater. And in the 80s, it might be that 10% of the US population had a BMI of 30 or more. And now today, in 2024, 42% have a BMI of 30 or more. And this is not due to changes in our genetics. It's also not so much on the individual level, but the changes we're seeing in the food environment and the built environment that's really causing these large shifts in prevalence of obesity. And there's been data showing that that large increase in prevalence is due to only about a 200 calorie change per day in either what we're eating or what we're expending. And we know that with technological advances, cell phone use, working from home, we're more inactive, and added sugar to our diet has led us to either drinking more calories a day than 2, 3, 4 decades ago.
And I always find this interesting. What are the states where obesity is the least common, where we have the perhaps fittest populations?
Yeah, so I think Colorado's number one for the lowest levels or prevalence of obesity. And that could be because there's a lot of opportunity to be active in that state. I'm not as familiar with their state level policies regarding food, but I know from a physical activity perspective, there's numerous opportunities out there. So yeah, you can definitely look at all this on a state level and look at differences.
And even a city level, because my understanding is that New York City is actually a city where obesity rates are in fact quite low. And I think, as you mentioned before, people are walking less, but in New York, they still walk.
Yep. 10 city blocks is about a mile.
So maybe we can just continue on this focus on weight and diet and cancer prevention. What do we know about this?
Yeah, so we know that a higher weight or higher adiposity is a risk factor for
Can I just stop you there for a second? Yeah. So there's been a lot of talk recently about weight versus the way that weight is distributed, and whether there are people who are healthy overweight. And maybe you could just comment on sort of adiposity versus obesity.
Mm-hmm. Yep. So as I mentioned, obesity defined in a population level is measured from body mass index, which is really just our weight adjusted for height. Because the taller you are, the more likely you weigh, the heavier you weigh. And so you adjust weight for height. And so that does not take into consideration the amount of muscle or fat tissue, what we also call adipose tissue. So there are a number of ways to assess body composition, the amount of muscle, lean mass, adipose, or fat tissue that an individual has. And it's really the adipose tissue that is related to cancer and other outcomes, diabetes, heart disease. And to your point, there's other, visceral adipose tissue, the internal body fat versus subcutaneous, which is right under our skin. The subcutaneous adipose tissue seems to be not as concerning as the visceral adipose tissue. And then there's where you distribute it around your waist versus around your hips. And distributing around the waist increases your risk for certain diseases, including cancer, more so than if you distribute it elsewhere. And there's a number of ways we can measure this through different scans, DEXA scans, CT scans, MRI, and whatnot. And so there's a lot of research looking at that. And to your point, there are people who might have a high BMI that puts them in the obesity range, but they might be metabolically healthy, meaning they have low glucose, triglycerides, cholesterol, insulin levels, even though they have a high BMI. And then there could be those who have a low BMI in the normal range, the under 25 BMI, who have high cholesterol, blood pressure, metabolic syndrome. And so I think, on a population level, we can look at sort of BMI levels and its association with various outcomes. But on an individual level, it's important to kind of know a little bit more about not just your weight, but maybe your body composition and your metabolic profile.
Because some incredibly fit person could just be muscle bound and, have a huge amount of body mass in muscle, and presumably wouldn't be at risk for many of these negative outcomes.
No. So if someone who has a lot of muscle mass, it is true, muscle weighs more than fat, and they might have a high BMI because they're quite muscular. And be concerned because if they just Googled BMI charts and put it in and find that their BMI is at 27 or 28 or 29, but there are other measures. Then you could do a waist circumference measure. You could do, other measures to that person can be rest assured that they are have lower adiposity.
And you used a term that I'm not sure that all of our listeners are going to be familiar with, and that is metabolic syndrome. and what characterizes a metabolic syndrome?
Yeah, so metabolic syndrome is a clustering of a number of factors, and it's usually defined as having 3 or more of these factors. So it includes waist circumference of a certain, amount, blood pressure, triglycerides, cholesterol, and a number of other factors. So if you have 3 or more of these and they're clustering, it's called metabolic syndrome, rather than just looking at one of these metabolic factors alone. Having 3 or more puts you at higher risk of cancer and other chronic diseases.
Got it. And do we understand why it is that abdominal obesity is riskier than, for example, obesity that may accumulate in one's legs or lower torso?
Yeah, definitely. So it's where it's located, close to the liver and close to other internal organs, and the interplay that might have in raising your risk for various diseases, whether it be the crosstalk between the liver and the adipose tissue. Adipose tissue is not inert like we used to think it was 3 decades ago. It was in the 1990s when leptin was discovered. And we learned that role it played in being released from adipose tissue and interacting with other organs in the visceral area around the liver that causes higher risk for various diseases.
And of course, even if we put cancer aside, there are many reasons why having too much body weight, that is too much unhealthy body weight in the form of excessive adiposity, has a negative impact on people's health.
Yeah. So a higher BMI affects joints, your ability to walk. There's a lot of stigma around high BMI, and so that can affect quality of life. It might even affect access to care if people feel stigma with their weight or with their body mass index. There's, of course, associations with diabetes, heart disease, even evidence relating to Alzheimer's as well. So there's much to be learned about the role of weight, adiposity, and managing our weight on improving outcomes.
And of course, it's a complicated problem, and it's hard for people to lose weight. And the last thing that people need, I usually think, is someone who's very judgmental about these issues, since that just worsens the stigma.
I couldn't agree with you more. And I think that goes back to the beginning of our conversation, and with the major societal changes that have occurred in our environment, our food and built environment, that have made it difficult to sort of access healthy foods or places to exercise. Those shifts have led to these high rates of obesity. And so we have to kind of think about how can we change those factors in our food and built environment.
Well, we're going to take just a brief break, and we'll be back with my guest, Dr. Melinda Irwin, and we'll focus more on both steps we can take to improve cancer outcomes and prevent cancer through diet and exercise.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, offering spiritual care to patients and caregivers seeking peace in the midst of their cancer journey, while respecting the philosophies, spiritualities, and religions of patients and caregivers. SmiloCancerHospital.org. The American Cancer Society estimates that nearly 150,000 people in the U.S. will be diagnosed with colorectal cancer this year alone. When detected early, colorectal cancer is easily treated and highly curable, and men and women over the age of 45 should have regular colonoscopies to screen for the disease. Patients with colorectal cancer have more hope than ever before thanks to increased access to advanced therapies and specialized care. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for colorectal cancer. Tumor gene analysis has helped improve management of colorectal cancer by identifying the patients most likely to benefit from chemotherapy and newer targeted agents, resulting in more patient-specific treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Eric Weiner with Yale Cancer Answers, and I'm continuing my conversation with Dr. Melinda Irwin, professor at the Yale School of Public Health and Deputy Director of the Yale Cancer Center. Melinda, so good to hear all of your comments. And let's focus down now on what we can do in terms of helping our patients. First, let's talk about people who have established cancer. So I am a patient with cancer. I come in and let's assume that I am significantly overweight. What are the risks that I face, and what do you think, either now or in the future, are steps that we can take to improve how I'm going to do?
Whether you're newly diagnosed or you've completed your treatment, I think that a high BMI or high adiposity can adversely affect your risk of recurrence and mortality, partly through various metabolic pathways and inflammatory and immune pathways. There's been hundreds of studies, associations, and clinical trials showing that a higher BMI can lead to adverse changes in various biomarkers, and also could have adverse effects with inflammation. We know all of those factors, such as inflammation, increase cell proliferation, increase risk of recurrence and mortality. So, the research that I and many others have done in the post-treatment setting have found that intervening with exercise and nutrition can lead to weight loss of about 5%. And that weight loss can be sustained over time. And that amount of weight loss favorably leads to changes in CRP, insulin, glucose, leptin, and other biomarkers. What we have learned in our trials, and others have learned as well, though, is that patients actually, when they learn of the benefits of exercise and nutrition, let's say 2 years after diagnosis, they kind of have this moment where they're like, why didn't I learn this earlier at diagnosis? So really my vision is that when a patient is diagnosed with cancer and they see the surgeon and the oncologist, they also at the same time see the registered dietitian, the physical therapist or exercise trainer. And at that time during treatment and then after treatment can get knowledge, increase their knowledge and skills about how to eat healthy and exercise through treatment and beyond. Because it's really that 5% that can lead to favorable changes. And in fact, the group that has the most adverse changes are those with a lower BMI. And we know that some treatments can cause changes in body composition, adverse changes. And so what our goal really should be is to prevent muscle loss, prevent increases in adipose tissue, prevent sarcopenia, cachexia. And so if we can do that in a sort of a triage approach with patients at diagnosis and revisiting them, say, every 6 months afterwards, I think it can really improve various outcomes.
It would seem to me that for at least two reasons, if we were to institute a plan where everyone saw a physical therapist and a dietitian, for example, that's an approach that should be taken not just with people who are identified as being overweight, but really with everyone. And I could imagine, and I just want to see what you think about this, that the reason to do that is, number one, you don't want to stigmatize the people who are overweight. And secondly, even for those who aren't, there may be some benefit associated with exercise programs and with some number of dietary changes.
So for patients who receive chemotherapy, we know that there are what we call nutrition impact symptoms, a lot of side effects of the chemotherapy. So even if those individuals were eating a very healthy diet before diagnosis, it only makes sense to have them meet with a dietitian during chemotherapy to make sure that their quality of their diet is maintained while they're facing these nutrition impact symptoms. Furthermore, there can be those who have a healthy BMI, but they are not really active, and that treatment puts them into a where they're going to lose some muscle mass that in turn might lead them to losing ability to do certain activities, whether it be work related or home related, or activities they enjoy, such as gardening or whatnot. So I definitely think that seeing these supportive care services at diagnosis and throughout can only be beneficial. And there are ways to do it where the patient with the dietitian and the physical therapist can decide how much or how little they need based on their knowledge and what they were doing before their diagnosis. So it's not like a one size fits all, but it can be sort of a triaging in different levels of care.
And you've done studies looking at exercise and diet interventions. Do you want to tell us a little bit about those studies and what they've shown?
Yeah, so we've done a number of trials across the cancer control continuum, during treatment, after treatment, various different outcomes. And there's overwhelming evidence that these, and we've done studies of exercise alone, exercise with nutrition, exercise and nutrition focused on weight loss. But each of the studies has found some evidence of an effect. For example, we did an exercise trial in women taking aromatase inhibitors for breast cancer who experienced a lot of joint pain and in turn made them not adherent to this really important medication. Or they actually stopped taking the medication. And the primary reason for that was the joint pain. And so we showed that exercise attenuated that joint pain, in fact, reduced it by 30%. Then we've done studies of diet-induced weight loss with exercise on blood-based biomarkers and also on tissue biomarkers, seeing favorable changes in the immune and inflammatory pathways that directly impact tumor growth. And then we've done studies during treatment looking at treatment outcomes. In a recent study, we found a suggestion that exercise and nutrition may improve pathologic complete response among women receiving neoadjuvant chemotherapy for breast cancer.
And just to be clear for our listeners, what that means is that in this preliminary finding, the suggestion was that in women who received upfront chemotherapy before they had surgery, that as a association, as a result of the diet and exercise intervention, that more women had the entire cancer disappear, which is important because that then can correlate with how someone does long term.
Yeah, and while these are preliminary findings, it was primarily found in women with triple negative breast cancer, and it's really important that we focus on that breast cancer. So the new trial we're going to start is specifically in that patient population, and it's important to focus on triple negative breast cancer because they do have some of the worst mortality outcomes with that diagnosis, and it could be because there's fewer treatment options available to them. So if we can look at the role of exercise and nutrition, improving various serum and tissue-based biomarkers, it could be another way to give them something that they on their own, with the support of hospital systems and dietitians and exercise therapists could do to help improve their outcomes.
And of course, although we don't have results yet, there's been a 3,000-person study conducted in the United States in which half of the women had a diet and exercise intervention, half did not. It was mostly focused on diet rather than exercise. But we're waiting to see if, in fact, using a dietary intervention, we could prevent recurrences.
Yeah, so you're referring to the Be Well trial, right? And this is a really important study. Hopefully in a year or two, results will come out. And it was really focused on weight loss and about a 5% weight loss. And they found that at 2 years that those randomized to the weight loss group had a 5% weight loss. And those randomized to usual care had modest change or really no change in weight. And the effect that 5% weight loss might have on disease-free survival, which is the primary outcome, will be really important to know. If there is an effect, and I really believe that there will be an effect, then how does that change the standard of care? And if there isn't an effect, is it that 5% weight loss is not enough? We already know from the GLP-1s and from bariatric surgery that significant amount
the
of
GLP-1s are the weight loss drugs that are out there now.
Exactly. And so there's some, preliminary evidence that was presented at ASCO. It was more retrospective cohort analyses looking at those who had significant amount of weight loss through weight loss surgery or medication. So this is weight loss of about 15%, 20% loss in body weight, that has improved disease-free survival outcomes. So with Be Well, is 5% through diet and exercise also lead to an improved survival? And if not, maybe more weight loss is necessary. But I think in the next year or two, we're going to have a lot of interesting findings regarding the weight, the effect of weight and other factors on outcomes.
And one of the things that I've always thought was interesting about that study is they approached weight loss as something that can be accomplished in many different ways. And they had essentially a toolbox of diets so that if one didn't work in someone, they would switch and take a different approach. Maybe, go ahead, please.
Yeah. So that's so important in an efficacy trial, which the Be Well trial was. And so efficacy, meaning you want to make sure that the intervention group, that there's fidelity, that there's actual weight loss that occurs. But I think going back to public health and my sort of vision for the future is that we really have to look at how we sustain weight loss or prevent weight gain in the first place. And we even have evidence with the weight loss medications, the GLP-1s, that at 1 year, about 50% or more actually stop taking the medications. And so this sort of yo-yo behavior in weight, losing weight and gaining it back, could have some adverse outcomes as well. So I think we have to look upstream once again at our food environment and our built environment as how do we make sure that weight loss that occurs is then sustained long term, or how do we prevent it in the first place by looking at, the environment that we live in?
So it sounds to me as though if we're going to try to prevent cancers by preventing people from becoming overweight to begin with, that's probably going to take more of a societal approach than an individual approach.
Absolutely. And it's going to take a collective action of numerous industry, government, public health, community-based organizations, clinicians, scientists working together with our policymakers to create the changes on a societal level that will really get us back to the BMI levels that we were in the 80s and 90s.
Do you think that's feasible? Do you think that we're going to see a time when our society takes those steps?
We did it with tobacco control. And 50% of the decline in cancer mortality rates, that 30% decline in cancer mortality rates is due to tobacco control. We did that through policy by banning smoking in public places. We can do this with our food environment and our built environment.
Dr. Melinda Irwin is the Susan Dwight Bliss Professor of Epidemiology and Associate Dean of Research at the Yale School of Public Health. If you have questions, the address is canceranswers@yale.edu. And past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.